Hi there. Welcome, everyone. My name is Margaret Lynn Martori. I am a PEM physician at UCSF. Do you guys want to?
Sure.
Do you have
My name is Dr. Nato, or Nicole. I'm a PEM physician at Mass General Hospital Boston. Hi, my name is Lily. I'm a PEM physician at
Perfect. So today we're here to talk to you about practice-changing research, and tell me if I'm like obnoxiously loud with this microphone, please. But practice-changing research in pediatric emergency medicine, synopses of the best new papers of 2023 and 2024. A little bit of how we chose these papers. We basically went through the highest impact journals in medicine, pediatrics, and emergency medicine, as well as kind of like our pediatric emergency medicine specific papers, read through all the abstracts for the last year, and then kind of chose what we thought were the top and most impactful articles and have summaries here for you today. None of us have any disclosures. And we're just gonna jump into the articles, and then we'll take questions at the end. Okay. So, the first one is a JAMA paper called Development and Validation of the Phoenix Criteria for pediatric sepsis and septic shock. How many of you have heard of the Phoenix criteria? Okay, yeah, so this is definitely going around in the PEM circles. We have like a PEM listserv that I feel like there was an active conversation about this just this past week. And so a little bit of background, you may all know that pediatric sepsis is really difficult to diagnose, and our current scores and definitions have very low specificity, meaning we're capturing a lot of children who do not actually have sepsis. And so if you think about why, in 2005, when the previous sepsis guidelines were developed, they were really based on a definition of SIRS, which is, I'm sure you all know, the systemic inflammatory response syndrome, which includes heart rate, temperature, respiratory rate, and white blood cell count, plus like an infectious cause. And in 2016, there was kind of a change where sepsis was more being defined as kind of infection-associated organ dysfunction rather than SIRS criteria. And as more background, in 2019, the Society of Critical Care Medicine Pediatric Sepsis Definition Task Force was formed, and this consisted of 35 pediatric sepsis experts from 12 countries in 6 continents, with a goal to better define pediatric sepsis. And they've already done a bunch of stuff. So they've already done a global survey and a meta-analysis, which led them to the need for this study. And so what was this study? This was a retrospective cohort study. It's multi-center, including 10 health systems in the US, Colombia, Bangladesh, China, and Kenya from 2010 to 2019. And from these centers, they created a derivation set as well as internal and external validation sets. They then did a stacked regression model to predict mortality in children less than 18 years with suspected infection. Importantly, they included both lower and higher resource settings. They excluded birth hospitalizations and patients that were less than 37 weeks post-conceptual age. And again, they had that primary outcome of mortality, though they had a secondary composite outcome of early death, which they defined as within 72 hours of presentation, or needing ECMO. And they took all this data and used existing scores to create a final model, then used a modified Delphi process to vote on the final Phoenix sepsis scores. So, from all these places, they ended up getting 3.6 million patient encounters, of which there were 172,000 plus children with suspected infection in the first 24 hours. Those children had about a 1.2% mortality rate. Looking at the kind of breakdown of the patient population, about 84% were from higher resource settings, a little less than half were female, 67% had no known prior comorbidities, and 72% presented through the emergency department. They do note that there were some data issues where certain things that, some of the data they wanted to collect, which included physical exam findings, blood work, their outcome and their patient and clinical characteristics was missing. They specifically mentioned things like documenting like a GCS score or respiratory support, and we'll kind of go into some of the limitations of this at the end of this. So from this, they created the Phoenix sepsis score. And so it is broken down into 4 categories based on the organ. And then the definitions are, if you have 2 points or more, you have sepsis. And if one of those points comes from the cardiovascular system, that equals septic shock. you will notice there is no severe sepsis anymore. So they got rid of this category of severe sepsis, and SIRS, the criteria that makes SIRS, is not part of this definition. So I'm gonna go through each one of these systems and what they counted. And what you'll see is these patients were very, very sick. that even got a point. Okay. So for respiratory, your eyes may glaze over that they're mentioning PaO2 and FiO2 already, because I think in the emergency department, we are not commonly using these in our day-to-day care. But I think the important things as an ER doctor to take home is you got 1 point for any respiratory support. So if you're putting nasal cannula on for like treating some sort of, if you're worried about the respiratory system and giving nasal cannula, that got 1 point. And then for invasive mechanical ventilation, or IMV, you either got 2 or 3 points depending on the severity of your lung disease at that point. For cardiovascular, again, if you got any of your points came for cardiovascular and you met the definition of sepsis, you were in septic shock. The way they kind of made this in the table is a little confusing, so I'm gonna go through it. You got 0 points for having no vasoactive medications. You got 0 points for having a lactate less than 5, and then these were your like mean or MAPs, or mean arterial pressures, by age cutoff. And then you got 1 point for if you're on one pressor, 1 point for a lactate between 5 and almost 11, and then these were your MAP cutoffs. And then finally you got 2 points for being on 2 or more vasoactive medications for a super high lactate of 11 and a very low MAP. So these are super sick kids. Like I don't often get lactates of 5+ in children. So just as an aside, another paper we reviewed to give you some context was in PEC, or Pediatric Emergency Care, which was Nygaard et al. And they looked at lactate as a screening tool for critical illness in the pediatric ED. And they it was a single center study in Denmark, and they looked at patients that had lactates drawn and which patients needed immediate resuscitation and didn't. And there was no change in the median lactate scores. And the lactate amounts in those, to look at the not needing resuscitation, was 1.6, and the ones needing resuscitation was 1.7. So super low. So like the cutoffs that they're using in this definition are what my point is, they're quite high in all of these categories. For the coagulation system, these were kind of the cutoffs they used. They looked at platelets, INR, D-dimer, and fibrinogen, and kind of you had a binary 0 or 1 point based on your findings and results in those categories. And then finally, for neurologic, again, really sick kids, you got 0 points if your GCS was at least 11, which again, quite sick if your child is at a GCS of 11. They gave 1 point for a GCS of 10 or below, and then 2 points if they had fixed pupils, so very sick kids. So, take-home points, this is a new way to define sepsis, looking specifically at end organ dysfunction with specific cutoffs. It is data-driven, it does not involve SIRS, but it is not a screening or predictive tool. If you look at, I talked about how they had all these pediatric sepsis experts who came together to come with this definition, only 15% were ED doctors. So you can kind of see why a lot of the data was presented the way it is. And so this is not something in the ED that we are going to be using to screen for sepsis, but rather I think the importance for us to know is that a lot of our PICU colleagues and people that are like chronic, in the ICU, they will be using this definition in speaking about the severity of sepsis for these kids. In research moving forward, we'll be using this definition. So I do think it is important for ER physicians to know about this. Okay. My next study, and as a POCUS person, I have a particular, and really enjoyed reading this article, is on diagnostic accuracy of point-of-care ultrasound versus radiographic imaging for pediatric distal forearm fractures and RCT, and this is by Snelling et al. This was a multi-center Australian randomized controlled study. They did convenience sampling, and they included 5 to 15-year-olds who came to the ED with a suspected, importantly, non-deformed, so not deformed distal forearm fracture. And they got randomized to either getting POCUS or X-ray. And both of these were interpreted by the ED physician, both the X-ray and the POCUS, which is often common practice. And the 3 diagnoses they could give, they had 3 options, are no fracture, buccal fracture, or other fracture. And again, all these were interpreted by the ED clinician. An interesting thing is for their final gold standard diagnosis, they used expert consensus of a group of POCUS experts, that were ED physicians, radiologists, as well as orthopedists who had access to all the imaging studies that the patient ultimately got, as well as their follow-up information. And all patients that had an x-ray that was felt to be other fracture, not a buccal fracture, ultimately also got an x-ray as well. And then the training for the physicians who participated in the study was a 2-hour training course with a logbook of at least 20 scans, 10 of which were fractures. They also reviewed an image bank as well. And so what did they find? So they had 270 patients randomized, half in each group. A little under half were female with a median age of 10. And they did not miss any clinically important fractures in either group. Looking at the sensitivities, very similar between the POCUS and X-ray group, but the specificity was significantly higher in the POCUS group. And like looking at a couple, what was missed, it was often kind of misdiagnosed in other categories. So for example, in one POCUS group, patient was found to diagnosed by POCUS to have a buccal fracture, but was actually found to have another fracture. In X-ray, 4 were diagnosed with buccal fractures, but were actually found to have other fractures, and similar things like that. Importantly, again, there were no clinically important fractures missed, meaning if they got a splint, that was felt to be adequate care. And the kind of negative effects were some patients who were found to have a buccal fracture or no fracture were put in long-arm splints for a longer period of time. So take-home point is POCUS is accurate in diagnosing non-deformed distal forearm fractures, and actually is more accurate than ED clinician-interpreted X-rays. Okay, and then the final paper I'm presenting in my section is the prevalence of UTI, bacteremia, and meningitis among febrile infants aged 8 to 80 days with COVID, so with SARS-CoV-2. So in this study, this was part of the AAP Reducing Excessive Variability in Infants Sepsis Evaluation 2, or Revised 2 study, which was a large initiative of including full-term, previously healthy, well-appearing patients aged 8 to 60 who presented with a temperature of at least 38 degrees Celsius. And then in this study, they underwent COVID testing in the emergency department or hospitals. They included 106 hospitals in the US and Canada, and this study was a secondary part of that AAP Revised 2 trial. In total, they included 14,000 febrile infants with COVID testing, of which 3,700 were COVID positive. And this occurred from November 2020 to October 2022. And so for the results of this, I'll kind of walk through this table. But if you looked at all infants, so ages 8 to 60, patients who had COVID had significantly lower rates of UTI, bacteremia, and meningitis. So you can kind of look at the numbers here where the COVID negative group had almost an 8% rate of UTI, a 2% rate of bacteremia, and about 0.5 of meningitis, where the COVID positive group had less than 1% in all those categories, crossing 1% for the UTI category. And then in the older patients, so the 1 month and older patients, or 1 to 2 months, if they were COVID positive, they had even lower rates of UTI, bacteremia, and meningitis. Importantly, many of these patients, because they're following the AAP guidelines, received like inflammatory markers, which, as you know, consist of procalcitonin, ANC, and CRP. And of those, if you had a normal inflammatory marker and were COVID positive, you had even lower rates of bacteremia. Whereas if you were COVID positive and had an abnormal or abnormal inflammatory marker, you had an almost 2% rate of either bacteremia or meningitis. So it really did help distinguish of the COVID positive patients who also may have a concomitant serious bacterial infection. So the take-home point is UTI, bacteremia, and meningitis rates were all low in infants with COVID, all less than 1%. This is especially true in the 29 to 60-day-olds with normal inflammatory markers. Some important caveats are this study was during like during the COVID epidemic, and there was really, really high testing of COVID and a lot of circulating COVID around, and at that time, there were many less other respiratory infections floating around. So because of that, many of the patients that were testing positive for COVID likely were actually actively infected with COVID as opposed to just shedding virus. So that does affect how we interpret this data. If you look at other viruses, oftentimes the bacterial infection rate among virus-positive patients like rhinovirus or RSV ranges somewhere between like 2.5% to 8%. And so the findings in this study show a much lower rate. I don't think that this is necessarily saying that all like 9-day-olds with a COVID test, you're not gonna do a sepsis workup on them, but I think really looking at those inflammatory markers can be really helpful, and especially in the older kids, there is an argument that you could decrease testing as well. And we'll have questions at the end. That's okay. Great, thank you.
All right, excellent. So I am going to bring you through the next few articles, the first one of which is somewhat related. It's again looking at a lot of the work that's been done recently in the world of infant fever, and how to, again, like looking at what variability exists in that care, and some ways in which we might need to consider trying to work on decreasing it. So this is a study specifically on the role of race, ethnicity, and language in the treatment of low-risk febrile infants. So this is a multi-center retrospective cross-sectional analysis. It included 34 hospitals over a 2-year time period. It encompassed approximately 4,000 infants that were 29 to 60 days old, and that per the inflammatory marker criteria that Margaret just went over, Dr. Lynn just went over, these infants all met those low-risk criteria, having presented with fever. So the exposures that they analyzed were the infant race and ethnicity, and the language that was used for the medical care at that visit, or language the family used for medical care. Primary outcome was receipt of one or more of these non-indicated interventions by the sort of AAP infant fever guidelines. And so it was either lumbar puncture, antibiotics, admission, or any combination of the three. The primary outcome of one non-indicated intervention occurred in almost a quarter of the infants, so 969. Race and ethnicity were not associated with receipt of that outcome. Language other than English, though, was. There's an odds ratio of about 1.16 for any non-indicated intervention at all, or 1.08 for specifically non-indicated admission, which, you know, not outrageous numbers, but in terms of thinking about sort of what that means in terms of the percent of families, you know, having to potentially miss work, having the stress of a hospitalized infant, the sort of effect on that bonding time, difficulty with childcare of other children, et cetera, is not unimpactful, I'd say, to our families. So the take-home points here are that inequities related to patient and family language do appear to exist in our evaluation and treatment of low-risk infants presenting with fever. Might suggest that there's likely some room for optimization of communication, and that might merit focus in our individual practice. I would say that this is a little bit of editorializing, but I would say that the authors of this study did editorialize a little bit at a suggestion that maybe this was reflective of inadequate interpreter use during sort of our index visit. Anecdotally, I think that many of us worry about the rest of the medical system's ability to properly care for these families in terms of follow-up, in terms of when they call the clinic. Will an interpreter be used at that time? And whether that's somewhat paternalistic or not, I think is unclear. But so I would suggest that perhaps the work is not just to optimize our own, communication within ED visits, but also to encourage our systems to ensure that that is happening. Or perhaps upon discharge, a practice I've taken away is to try to avoid that paternalistic desire to keep the patient just because of language, but make sure that I say not only to call their pediatrician, but if it's at all within our system, to say here's the interpreter line phone number for how you call, and have the interpreter get a hold of that front desk to make the call. And then otherwise, I would just say this is, I think, a common ongoing theme in sort of quality improvement right now, which is that anytime that we work to reduce variability or to improve care, we need to give active attention to equity. Otherwise, what we may unintentionally do is actually increase inequity in care. And so just really merits important focus as any of us try to roll out these clinical guidelines at any of our institutions. All right. Moving on to the next study, which is the management of children and youth with pediatric mental and behavioral health emergencies. This is a little bit different, and it is not sort of primary research or other policy statement, but I did think was really worth bringing here, particularly with what an enormous focus this is right now. I feel like when you ask any of us about our stresses in the ED, in the top 5 almost always is like adult medical boarding and pediatric sort of mental health boarding and challenges with resources and prolonged length of stay. So I thought pertinent for all of us. This is a joint position paper between 3 professional bodies, the American Academy of Pediatrics, as well as the American College of Emergency Physicians and the Emergency Nurses Association. The goal was to highlight ways for improving emergency care delivery for pediatric mental and behavioral health patients in the ED, and they outlined a multitude of strategies, resources, and recommendations, which really were multifaceted, and some included, many included things that sort of at the systems level, at the policy level, at the advocacy level. I tried here to distill it down to just a small handful of things that might be valuable to any of us as like individual clinicians, or perhaps just like slight champions at our sites, knowing that our ability to impact on some of those higher level of things as individuals is somewhat lower. Of the many things that they outlined, some that were really like discrete, concrete, like achievable things with relatively low resources. One was education of ED staff in these like discrete, mostly data-proven, effective interventions. So safety screening, making sure that there is a standardized way in which patients coming in are, for any mental behavioral health complaint, are being screened for risk of harm to self or others. Safety planning, so ensuring that in any patient with such presentations in whom discharge is being considered, that a safety plan is completed. And particularly lethal means education and counseling. So are there firearms in the home? If a patient has presented with SI, for instance, but ultimately is felt to be safe for discharge, are there firearms in the home? How are they locked and stored? Potentially, if they're on particularly toxic, medications, at high risk of overdose, et cetera, how do we store them? But really focusing on pragmatic, practical safety steps that families can take. Another one of their major recommendations was utilization of ED clinical pathways and then creation of a safe ED environment. These can both feel a little bit daunting or nebulous in terms of like, okay, great, but who's going to be the content expert to make that pathway at our institution? And I do want to highlight, I don't have a slide about it here, but anybody else is welcome to come up afterwards. There's really incredible work being done by one of the authors of the study, as well as a number of other collaborators, to make really wonderful free resources available. So specifically, they have made a sort of clinical guideline and algorithm for the care of pediatric mental behavioral patients, as well as sort of a guide specific for medication recommendations for agitation. And then also have created sort of a whole packet in terms of creation of a safe and I'd say sort of pediatric-friendly ED environment, one that might decrease agitation by giving sort of positive stimuli, et cetera. They've created a resource with sort of safety approved, for instance, like minor toys, like things that have already been documented as safe to give to children with risk of self-injury, and how to order them, all quite low cost. They've created a binder that can simply be printed with resources such as the safety planning that I mentioned, such as daily schedules that can be printed out to be made for kids, and all very like open access to the public, and I think can be really tangible resources. So again, I'm happy to show anybody after the talk. Okay, so take-home points. There are small, concrete steps that are in the hands of us as individual EDs and physicians. Most of the improvement actions called for are at the systems level, but the good news there is that it is also making it sort of an area currently ripe for both research and advocacy. So if anybody has particular sort of passions or interests, it's definitely a very active area right now. All right, moving on to antibiotics. I think one of the sort of hot questions of the moment seems to be kind of what occurs somewhat often is like less is more becoming sexy, and like can we do shorter courses of antibiotics for pneumonia, for urine infection, and so we'll talk about each of those in our next few studies. So this particular study, shorter versus longer term antibiotic treatments for community-acquired pneumonia in children, it's a meta-analysis. It encompassed 16 studies of pediatric patients diagnosed with pneumonia and treated with outpatient by-mouth antibiotics. And the objective was to compare the efficacy and safety of shorter versus longer duration of antibiotic therapy. So it encompassed about 12,000 patients. You'll see on this forest plot here, and I'll call your attention to the sort of far left column. This is one of the challenges with drawing an exact conclusion. But the various studies looked at different markers of what they called short versus long. So the first sort of cluster there was 3 versus 5 days. The next cluster was 3 versus 10 days. The third cluster was 5 versus 10 days, and the final cluster was 3 versus 7 days. So different meanings of short versus long, but these are the studies with which we have to work. But you can see on the first plot there was no difference whatsoever in clinical cure, treatment failure, relapse, mortality, need for antibiotic change, need for admission, or severe adverse event. So I'd say our take-home points here were that shorter antibiotic courses seem to be non-inferior for pediatric outpatient pneumonia. Consideration of shorter courses may be quite safe and reasonable, although perhaps, at least from this study, the optimal duration of therapy isn't clear. I will say, all the murmurs sort of out of PAS, people seem to be landing on 5 days, which I think, given the sort of spectrum of those studies, seems reasonable and the right patient population. All right, so moving on to UTI, there's been a bit of a dueling UTI studies this year. The study on the left, whose clever acronym I forget, it might have been SHORT, but I might be lying to you. But either way, short oral antibiotic therapy for pediatric febrile urinary tract infections and RCT, or the SCOUT randomized trial, short course therapy for urinary tract infections in children. So we're gonna look sort of comparatively at the methods and results for each of them, because notably they were quite different, which posed a little bit of a challenge. So the methods of the first study, both are multi-center RCTs. The first study had about 142 patients, aged 3 months to 5 years. And it basically was all comers in that age group that presented with what was determined to be uncomplicated febrile UTI. Their exposure was a 5 versus 10-day antibiotic course, with primary endpoint being UTI recurrence at 30 days. Secondary endpoints being clinical recovery, adverse drug events, and resistance on culture if a recurrent UTI was identified. The SCOUT study had a little under 700 patients. They were aged 2 months to 10 years. And this was a differently selected group in that it was patients with UTI that were exhibiting improvement at 5 days. In those patients, they were then randomized to an exposure of either an additional 5 days of antibiotics or placebo. The primary endpoint was symptomatic UTI, sort of at or by day 11 to 14, with secondary endpoints being UTIs day 24 to 30. These are the 2 points of follow-up. So UTI like at or by their follow-up at day 24 to 30. Asymptomatic bacteria, positive urine culture, GI colonization with resistant organisms. In terms of the results, the first study, quite interestingly and a little bit difficult to understand, there were 5 versus 10-day antibiotic course recurrence. Recurrence within 30 days was 2.8% in the 5-day group and 14.3% in the 10-day group, with febrile recurrence being 1.4 versus 5.7%, although that did not reach statistical significance. There were no statistically significant differences in secondary outcomes. So again, I think perhaps a little bit biologically difficult to understand in terms of the biologic plausibility there, but that is the data that they had and presented. The SCOUT study, again, a different population. It's among those that had shown clinical improvement at day 5. But in that patient group, their rates of recurrence at the 11 to 14 day mark, which was their primary outcome, was 4.2% in the 5-day group versus 0.6% in the 10-day group. Asymptomatic bacteria was 3.4 versus 8.6, positive urine culture 1.8 versus 12.2, and no difference in any of the other outcomes that I had outlined before. So quite different results. I would say, I guess this is editorializing a bit, but here we are. The SCOUT study, the sort of one on the right, apart from having perhaps more biologically plausible results to easily understand, also was the larger of the studies significantly, but again, important to note that it was a different patient population going in. So I thought this was a nice analysis here. I think what we care about probably a little bit more than the asymptomatic bacteria, et cetera, although hard to know in our younger patients who can't tell us symptoms always, the importance of, say, that positive urine culture, that sort of third blue box there on later renal scoring, et cetera. But to eliminate the primary outcome, you would need to treat 28 patients with a sort of full 10-day course versus 5, and then sort of 19 or 10 for the other outcomes that you see there. So I would say the take-home points here are that short course antibiotic therapy my take-home is that it does not appear to be non-inferior to standard course in all pediatric UTI. That said, it may be reasonable to allow for early termination of antibiotic courses in children with clinical improvement at day 5, perhaps in those whose presentation was most suggestive of cystitis. My feeling is it's likely prudent to maintain a 10-day course, at least for anybody suspected of having pyelonephritis. I think in terms of that middle bullet point, I think this may be, again, as is so often an emerging theme, maybe an area for shared decision making, right? We may think well, I'm just going to prescribe 10, great, the 4% versus the 0.8% the recurrence or whatever those exact numbers were. But it may matter the parental preference on how much they worry about antibiotic exposure and biome, et cetera, or probably more likely and more pragmatically how desperately they have to tackle their toddler every day, twice a day, to continue that antibiotic course. And so some families may say, I have a 96% chance of cure, without recurrence, with just a 5-day and saving myself what may be actually quite traumatic additional 5 days, great. Others may feel differently. And so it may be an area to bring families into decision making. All right, and we'll move on to our Dr. Lee.
All right, so the next couple of articles we're going to review are around pediatric trauma. The first one is which pediatric trauma severity scores are useful in predicting pediatric mortality. So there are several different pediatric trauma scoring tools that people can use. I think typically most people know about ISS, the injury severity score, but that's calculated at the end of discharge after you know where all the injuries are. So these tools are helpful in that they're based off of the first ED vital sign. So shock index is typically used more in adults where it's heart rate divided by systolic blood pressure. They've created SIPA, which is the shock index pediatric age adjusted, which is the same heart rate divided by systolic blood pressure, but you have different cutoffs based on the age of the patients. And then there's reverse shock index, which is the blood pressure divided by the heart rate, and then reverse shock index times the Glasgow Coma Scale, and so there are all these different scales, and this study was trying to look at which one is the most accurate at predicting mortality. So this was a retrospective review of the 2015 National Trauma Data Bank, all children ages 1 through 18, and they used that first initial vital sign in the emergency department, and they looked at mortality as the primary outcome. They had 67,000 patients with the mean age of 11 years. Most were admitted, 15% went to the ICU, 17% to the OR, and 3% mortality rate. And what we find is that the shock index, the reverse shock index times GCS, and were predictive of mortality, but SIPA was only predictive of mortality in the older age groups, which is kind of interesting. And out of all of these, the most predictive one was the reverse shock index times GCS. And I think most places probably are not using this as a screening tool, but this theoretically would be something you could implement into your EHR and create a flag to be like, hey, watch out for this patient. I think we've all heard of cases where, the pediatric patient holds on for so long and their vital signs seem normal, and then all of a sudden they fall off that cliff. And so maybe this would be an early marker for when we can give a blood transfusion or take them to the OR. So the take-home point here is that the reverse shock index may be best for mortality prediction in all ages, whereas SIPA was really great for the older age group. All right, so next trauma article is the association of pre-hospital transfusion with mortality in pediatric trauma. So this was an interesting article in that in Pennsylvania, they're able to give blood transfusions pre-hospital. So this was for children ages 0 through 17 who received blood transfusions either pre-hospital or in the emergency department over a 10-year period. And their primary outcome was to look at 24-hour mortality versus in-hospital mortality. So they had a total of 559 patients. 13% received pre-hospital transfusion, 87% received an ED transfusion. And interestingly, the pre-hospital group had lower odds of 24-hour mortality and in-hospital mortality compared to the ED transfusion group. So our take-home point here is that, with pre-hospital transfusions, you have lower rates of mortality compared to patients who received a transfusion in the emergency department. And the number needed to treat would only be 6 pre-hospital transfusions to prevent 1 24-hour mortality. Or you could have 5 patients receive a pre-hospital transfusion to prevent 1 in-hospital mortality. So currently in my system, we're not doing pre-hospital transfusions, but I think this article really points towards maybe we should consider it for pediatric trauma patients. All right, so our next article is focused on mortality in adolescents and young adults after their first presentation to the emergency department for alcohol use. This was a retrospective cohort, 2009 to 15. This was all done in Canada, so all the patients were able to be tracked throughout their years. So these were children and young adults ages 12 through 29. They looked at patients who had their first emergency department visit for alcohol, and then they matched those patients with those in the same age, sex, household income, mental health, substance abuse for non-alcohol related ED visits. And then they looked at outcomes of death within 1 year of that first ED visit for alcohol, and then death within 3 years of that first ED visit of alcohol. You just want to think in your head, like, what's going to be the result here? So they had 71,000 patients who had an ED visit for alcohol only, and then over 2 million ED visits for non-alcohol complaints. And what they found was that at mortality rate at 1 year for that patient who had the first time ED visit for alcohol was actually 3 times higher than all the other patients, which is actually quite high when you think about the 1 year mortality. And then even the 3-year mortality was a little bit high as well, 3.76. So it's pretty significant when you think about it. And you might be wondering, well, what's the cause of death for these patients? So for alcohol, the top 5 causes were trauma, non-opioid drugs, alcohol, opioids, and self-harm. And in the non-alcohol group, the only 2 that match here are trauma and self-harm, but then other causes were cancer, cardiac, and respiratory. So I think our take-home point here is that, for that patient with that first-time ED visit for alcohol, they're very high risk for 1 and 3-year mortality. And what was an interesting finding in the study that isn't highlighted a lot, but is that the mortality was actually even higher for those who just came in for alcohol. So patients who had alcohol plus mental health or other substance abuse problem actually had a lower mortality rate. And in California, we have a state funding program where we can apply to get a substance abuse navigator. And I think typically most people will ask the substance abuse navigator to see our ED patients if they come in for opioid or methamphetamine related complaints. And then the substance abuse navigator will give them fentanyl test strips so they can test their drugs or Narcan. But I think with the study, I think I would probably be more inclined to also target patients who are coming in with alcohol use in their adolescent and young adult period, just to have some extra support and some teaching while they're in the emergency department. All right. And then the last article we're going to go over is the recommendations for choosing wisely in pediatric emergency medicine, 5 opportunities to improve value. So this is more, not a randomized controlled trial, but this is more like opportunities where there's been national consensus on how do we improve value in our pediatric emergency department. So this was initially started by taking suggestions from 33 ED clinicians from 6 academic pediatric hospitals. Then these items were rated for frequency of overuse, degree of harm, and what the evidence is behind using it. And then they were reviewed by US and Canadian pediatric emergency medicine physicians who had quality improvement expertise. And then they were externally reviewed by over 100 stakeholders through the AAP, Choosing Wisely US, and Choosing Wisely Canada. So there are 3 phases where they narrowed down the top 5. So initially started out with just 219 free responses that were collected from all these physicians, and then they scored them, and then basically at the end they came down to the top 5 that they have created as the Choosing Wisely campaign. So I'm going to spend more time just talking about all these different recommendations. The first recommendation is do not obtain a routine chest x-ray in children with bronchiolitis, croup, asthma, or first-time wheeze. I think the yield is actually very low. This increases their ED length of stay and actually adds to their cost and the small amount of radiation. But of course, if you have a child who's not improving or there's a focality to their finding, then this is when you would do a chest x-ray. Their second point is do not obtain routine screening labs for medical clearance of psychiatric patients unless clinically indicated. I feel like this is like a very common thing we run against. What I find interesting in our emergency department is like we don't obtain routine screening labs for the very young children, you know, like 8, 9, 10, like we don't routinely obtain them, but always for the teenagers we obtain them. But you know, obviously this causes delay in transferring their care to the psychiatric facility. So if you could try to push back using this national guideline, it might be helpful in your department. Third one is you do not need to obtain labs or a head CT for a non-high-risk pediatric patient who has an unprovoked generalized seizure or simple febrile seizure who has now returned back to baseline. So this means you don't need, just because it's their first time having a seizure, as long as they're back to baseline, you don't need to get a head CT or labs. High-risk patients would include, you know, patients with cancer or sickle cell, or patients who are not returning back to their baseline, or they had focality with their seizure. These are patients that you would probably obtain labs and a head CT, but for the most common seizure that we see, where the generalized tonic-clonic lasts like 1 to 2 minutes, and now they're back to their baseline, they don't need it. The fourth recommendation is that you do not need to obtain routine abdominal x-rays for suspected constipation. This should really be based on your history and physical exam and using the Bristol stool chart. You shouldn't need to get an x-ray to confirm that, you know, this patient has constipation. And then the last take-home point is that you do not need to obtain a comprehensive viral panel testing for patients who have suspected respiratory viral illnesses. You know, I think everyone has like the 12 respiratory viral panel that you can obtain, which is, you know, very expensive, but it rarely changes your management. So for most patients, they don't need it. But if you have a patient who's a hem-onc patient or they've had prolonged fever for now like over a week, then those are patients that you could consider using it. But for the most part, they're not very helpful. And it doesn't change your management. So these are our references. And we're open for any questions if you have any.
Did you have a question?
So the COVID febrile infant really hit home because I had several, like febrile 5-week-olds, their whole family had COVID, and then I'm like, okay, I'm going down the pathway, but we know that COVID causes leukopenia and elevated CRP and procalcitonin. So I had several where the white count was 4.9 as expected. So for inflammatory markers, that triggers you into the pathway. So have you been following it to the letter? Like we might talk about like, so like when you talk to the pediatricians there, they're like, well, no, that's viral suppression, so therefore the other stuff is fine.
So it's a great question. Like if you look at the rates, I'm thinking of the 29 to 60-day-olds
Yeah.
that had COVID and a positive inflammatory marker, the rate was 1.8%. It wasn't like 10%. So
Right.
you are going to, yeah, we can go back to that slide. You are going to, it's a risk tolerance. So like even in the paper, what they're talking about is what's your risk tolerance?
Right.
And I think you were doing this while I'm assuming there was like lots of COVID around it. You can argue now,
Right.
I don't know what the COVID rate is like
Right.
generally in Phoenix at this moment or wherever you're practicing. But I think that's what you have to take into account. And so there is a risk benefit, and there's a lot of what is your risk tolerance
Right.
and what is the family's risk tolerance.
Right,
So this is a case where I think, you know, again, in a 9-day-old, I just think our
Yeah.
general
Yeah,
risk
yeah.
tolerance is not going to be there. In a 5-week-old,
Right.
where you're like, hey, I get this, but that means the risk is probably around 2%. That is a border, or like just under 2%. That's the borderline for when many people will do testing, is right around 2%. So then it comes to this risk. I think Nicole.
But also, like, what about, you know, there are different inflammatory markers, like one of them, leukopenia, is a known thing that happens with COVID as opposed to like leukocytosis, you know, for
Yeah, so I was just double checking myself to make sure I wasn't misremembering. I made our institutional guidelines for infant fever based on the AP infant fever, and so I just wanted to double check. But I don't think I'm misspeaking to say that leukopenia is not on the.
It's an ANC, sorry. Did you
Yeah,
say-
so
It's
a white
ANC.
count, so a white count.
I'm sorry. Yeah.
No, it's okay. Sorry, but I think you had referenced a white count less than 5. So prior guidelines had wanted a white count between 5 and 15.
Yeah.
That's not currently one of them.
It's an ANC, CRP, and procalcitonin are the 3 cutoffs.
Yeah, and even at that, you only sort of have to use CRP, or it's only like recommended if you don't have procal. CRP is the worst performing of the markers. So
Yeah, procal is ideal if your lab can do procal.
yeah,
And so,
Yeah,
that
exactly.
is like I have one place that does procal. The other one did it for a long time, and now they do it. So because we basically our pen was like you need to get this, like this is part of it.
Yeah, we similarly, like the evidence for ProCal in these infants is so strong that we similarly were able to get one of our like community sites within our enterprise to approve getting ProCal for this indication. But yeah, so if you're able to send ProCal and ANC, you don't need to send CRP, and it almost gives you just more chances to strike out. It's much less performance. They have much poorer performance. So we recommend that. So the sort of old 5 to 15 is not a part of it anymore on the white count. So maybe, you know, I think as everybody adapts, if it's an institutional guideline you're looking at, and as people are adapting, they're sort of like melded together, old and new, which again sometimes gives like more chance for failure. So no longer an issue with leukemia.
Thank you.
Any other questions, comments?
Great, thank you.
It's always infant fever that people want to know.